Greetings, everyone. On this episode of our INDSI podcast, we're going to explore the connections between newborn screening and birth defect surveillance programs. We're fortunate to have with us Dr. Russell Kirby. Dr. Kirby is a perinatal and pediatric epidemiologist, and his work focuses on population-based studies of pregnancy outcomes, birth defects, and developmental disabilities. He's a distinguished professor at the University of South Florida. Welcome, Dr. Kirby. Can you tell us a little bit more about yourself and your interest in newborn screening?
So I've worked broadly in the field of maternal and child health for about 40 years. I was trained in geography. I earned a postdoctoral master's degree in epidemiology and worked in vital statistics for about 10 years in 2 different states. And it was actually there that I learned about both newborn screening and birth defect surveillance. And one of the things I've always been interested in is what I call data integration, which is not quite the same thing as interoperability, but closely related. The idea of how do we actually take multiple data sources that we might have and put them together in a way that allows us to answer questions that can't be answered, just from one of the data sources. And I've been interested in this because newborn screening, if it's done properly, you screen all of the babies who are born in a jurisdiction. And you would think that if you linked all of the newborn screening records with birth certificates, you would end up being able to look at patterns on a population base. Well, we do the same thing with birth defects registries. The goal is to identify any major congenital anomaly that occurs in a baby born in a jurisdiction. And again, we want to link those records with vital statistics. So it naturally makes sense that if you had both of those data sources linked to the birth certificate, then you could also look at relationships between babies with birth defects and babies with particular conditions that are screened by newborn screening. Additionally, it's always made sense to me that the newborn screening programs, which are designed to identify health conditions, particularly metabolic disorders, but also hearing loss and more recently critical congenital heart defects that might not be detected clinically. These are actually all birth defects. Just by the very definition of a birth defect, any baby who has a metabolic abnormality, it's a birth defect. So they've always made sense to me that they should be aligned in many different ways. Yet, in most states, they aren't. And the newborn screening program is handled as a separate entity. And in some states, now that we're thinking about doing newborn hearing screening, we're thinking about pulse oximetry screening, and more recently also potentially congenital CMV screening. We have separate databases, and we don't think holistically about how to put them together.
So given these relationships, what are the opportunities for newborn screening programs and birth defect surveillance programs to be working together for the benefit of both?
Well, I've thought about this a bit, and one area where there's a clear opportunity has to do with babies who might have metabolic abnormalities, that can potentially lead to, disabilities. Also thinking about hearing loss and potentially identifying babies with hearing loss who also have structural abnormalities of the ear that potentially could, by identifying that combination, could identify babies who are at higher risk and need more urgency in terms of having them evaluated and receiving interventions would be examples. Likewise, in terms of a pulse oximetry screening, where we're trying to identify asymptomatic cases of birth defects, putting the data together allows us to be able to evaluate how well those programs are actually doing at identifying those cases, and again, hopefully being able to do some kind of an intervention. But there's all sorts of opportunities with that. One of the areas that would be really important would be in terms of being able to look at longer term follow-up, particularly babies with metabolic disorders, for example, or neurosensory impairments. that potentially can be identified through newborn screening, and looking even further into the future and looking at whether they are connected with early intervention services or 3 to 5 educational co-op services or other kinds of services that can assure that they have optimal outcomes.
So if we're going to achieve these goals of sharing data between the programs, who needs to be at the table? Who else besides these two programs could be an important part of interoperability?
The one team that I think really needs to be at the table are the people who manage the vital statistics data systems in a state. And the way I look at it, the vital statistics are really the core for data integration, at least in maternal and child health. Maybe not so much in looking across the entire population, but looking at infants and young children. And all of newborn screening and birth defect registries and other similar data systems really need to be structured in a way where they have commonalities with vital statistics, or build scripts that allow you to harmonize data across them. The newborn screening records ideally should be linked with birth certificates. It's one of the core features of any kind of quality improvement program for newborn screening. How can you know if you've screened the entire population when you actually know the entire population through vital statistics? It's a natural kind of a thing. And birth defect surveillance is really in the same way. And so if you link the birth defects records with vital statistics and the newborn screening records with vital statistics, then by definition, you could link the newborn screening records also with the birth defects registry. Now, a lot of times people don't do it that way. I've seen a lot of projects where people have taken newborn screening records and linked them with special education. I've seen, in metropolitan Atlanta, where they have autism and developmental disabilities monitoring. I've seen them link newborn screening with that and so on. But the natural way to do it is by creating the core linkage with the birth certificate. And so you need to have the people who are, the designers and managers of your vital statistics information systems definitely need to be team players in terms of whatever integration one might be doing.
So as you've been working in this area, what barriers have you seen to sharing data? And are there solutions that you've seen be effective in overcoming some of these hurdles?
Okay, that's a really interesting question. And it's one that really depends on the state and the statutory arrangements whereby the programs operate. So I live in the state of Florida, and historically, the state of Florida's Organic Act governing newborn screening has stipulated that the data can't be shared outside the newborn screening program except to the providers for the child in question. And that means that it becomes more difficult even inside the state agency for data to be shared across other programs. So right now we have a major interest in doing better surveillance of sickle cell disease and thalassemia. Well, sickle cell disease is actually one of the conditions that's screened in newborn screening. And you would think it's a natural thing if you were building up a surveillance system for sickle cell disease that you could identify those records. Well, at least in Florida, that's difficult from a legal point of view. Might not be so in other states, but it definitely is here. There's also issues in terms of sharing data even within the programs. And again, depending on how well-funded the program is and what kind of legislation or administrative rules have been established, collecting information on diagnosis and treatment and outcomes sometimes is difficult. For example, do all pediatric audiologists routinely report on the results of the evaluations they do on infants who might potentially be seen for hearing loss? Well, maybe not. But if you want to actually have a comprehensive system for looking at outcomes, you need to find a way to make that happen. But there's another issue that that also is something that people don't talk about as much as they could. And that has to do with the fact that we are a very mobile society. And I'm a perfect example of that. I've lived in about 12 different states over my life. And, families move. Sometimes families actually sometimes move in relation to treatment accessibility for their child who might have a metabolic condition or heart disease and so on. And we need a system that also is supported not just of interoperability within programs within the state health agency, but we also need interoperability across states so that we can ensure that if a child who has a metabolic disorder that we're trying to track to make sure that they're getting the appropriate services, if they move to another state, we need a mechanism to pass that information to the other state. And that, of course, requires another level of interoperability, but it's something I think we need to be moving toward. This is a problem with birth defect registries as well. Most of the birth defect registries are designed to collect data about birth defects that occur to residents of a state that are diagnosed within the state and don't necessarily have a mechanism for capturing information on children who might be cared for in an adjacent state. And there's all sorts of examples where this is an issue. If you look at the state of Missouri, for example, the two major cities are both on state borders. Or if you look at Wisconsin and the Minnesota, the Twin Cities area, which is the primary higher level healthcare source for a large area of northwestern Wisconsin, and not having interstate exchange arrangements makes it really difficult to provide an approach that really captures the entire population. So those would definitely be some things I can think about in terms of sharing data. But I would also say, the institutional arrangements within which the program has to operate are oftentimes the source of challenges for this.
So do you think there's one thing that we could start with tomorrow to help advance data sharing between these programs?
Yeah, I do. I think the most important thing really is to sit down and take a systems science approach and think really broadly about who needs to be at the table in terms of thinking about how to make this happen. And within the context of that, really taking a careful look at what are the system requirements for any data sources or informatics applications that we might have, and build those in a way that they promote interoperability and enable these kinds of linkages to occur. And I've always been impressed by the way that people who come from the outside of a particular topic sometimes can give a fresh eye and identify things that sometimes are overlooked by people who are more experienced. And just as an anecdote, when the state of Virginia was implementing the new birth certificate a few years ago, my colleague Derek Chapman was the MCH epidemiologist, and he was sent down to talk to the consultant who was doing the system redesign. And he gave them all the requirements and talked about all the different variables and how they were going to use them and how they needed to be formatted and all those kinds of things. And he goes back downstairs a month or so later to talk to the consultant. And the consultant says, I was thinking about this, and I realized that there are a number of different fields in the database that really should be indexed. And obviously, we're going to index on the child. We're going to probably index on date of birth. But it occurred to me that the mother might appear in more than one record, and we might want to be able to keep track of that. So he built an index based on the mother's name, which automatically just transformed the entire database into one where you had the ability to look at maternally linked outcomes. So you could look at the characteristics of twins or triplets, or you could look at the characteristics of a second birth in relation to a first birth and so on. And this was an incidental feature that was built into the Virginia Vital Records system just because the developer thought, that's something that we ought to do. It wasn't something anybody asked him to do. He just took it on himself and was able to create an innovative feature because of that. And I think, again, when you're thinking about how to advance data sharing, again, the reasons why people might want to share data might not be obvious and apparent to them until they actually start working with the data. And a lot of times, really good ideas can't be implemented because they weren't built into the process. So having a systems approach is definitely an essential element in whatever one might want to do in terms of advancing data sharing or interoperability.
Yeah, I think that's a great example of how just some simple discussion between individuals with different perspectives can really bring about some meaningful insight. Well, Dr. Kirby, I want to thank you for sharing your time with us today. It's been a pleasure talking with you, and thank you for all your thoughts and expertise in these areas between the programs.
Yeah, and I'm glad to assist. And if anybody who's listening in wants to follow up, I'm pretty easy to find by email and happy to follow up with anything that might have sparked an interest.
All right. Thanks again, Dr. Kirby, for your time.
Well, thank you.